All right, so we're going to get started. It's my pleasure to introduce AJ Aga. He's one of our PGY4 residents. I've known AJ since he was a medical student at UCSF. He came to us right before COVID, and he worked in our lab. He also broke all the freezers that summer in our lab. So he was both the most persistent and least productive member of our lab. You might wonder, how unproductive was he? He spent probably 90 hours a week that summer in lab and had nothing to show for it other than all melted samples, which I think we blamed on Trump, which was absolutely fine. But he worked incredibly hard, had a lot. By the end, he had a lot of research to show for it, did a tremendous job pivoting halfway through the summer and got a lot done. We were thrilled when he matched here. We were a little bit still crushed that he decided to do spine. But then we're very excited that he decided to stay here, follow in his friend Dr. Wiggins' footsteps, and he's going to talk today about home call when family become patients.
This. So I actually met you first year of med school, Dr. Feely, and I showed up in a full suit and tie, which I could tell he thought was a little weird at the time. But I only did that because you had met with Joey Sheridan the week before, and he was in his street clothes, and you made a comment to him that he may have skateboarded to your meeting. So I made sure to dress to impress. But all right. Well, hi, everyone. Thanks for... No, he looked great in the street clothes. Yeah. Hi, everyone. So thanks so much for attending my talk today on home call when family becomes patients. So to start off, here are my disclosures, none of which are relevant to today's talk. And here's just a short clip from one of my favorite shows just to get things started here. Hopefully you guys can hear.
Just 20 minutes. Full deep breath. Excuse me, everyone. One of our passengers is taken ill. If there's a doctor on board, can you please ring your call button? Wait, breath.
For doctor. Oh, you're not going to hate the call? Give me a minute. He's going to be fine. At the end of it, you don't even know what he has. You ever been part of an emergency landing? Is that what you want, Larry? To spend the night in Lubbock, Texas at a Days Inn with a $15 voucher from Cinnabon? Think about it. That's honest.
So as many of you in the crowd, I'm sure, have had this experience at least one time while flying. It can be a jarring experience when you're thrust into a medical situation kind of outside your normal clinical or OR duties. Sometimes the responsibility in these scenarios are not so clear-cut. So some of the questions that may be popping up on your head may be on this wheel, such as, should I even identify myself at all? Am I even capable of providing any help to this situation? What questions should I ask? What exam maneuvers should I perform? Am I generating a proper list of diagnoses? How will I triage the situation? And what will be my final plan that I recommend to the crew? So all this is happening on the small confines of a plane. You also need to project a sense of calm and reassurance to the passengers aboard. And you're also feeling the pressures of the passengers, including yourself. You just want to get to the destination. And ultimately, all this may be out of your control when the pilot just decides to divert the plane regardless. So reflecting on times I've been on this situation while flying, it felt very similar to another situation when I was thrust into medical kind of confines, but this time within the confines of my own family. This time, my father taking on the role of the ill passenger, my mother and brother and close friends taking on the role of the crew, and my family's trajectory being diverted in its course. So approximately 3 years ago, my father was diagnosed with prostate cancer. He was undergoing his regular PSA screenings. And then eventually they essentially just spiked for him. This was followed by a bunch of biopsies and staging studies, which ultimately placed him into the intermediate risk category, where both radiation and surgical resection were viable options for him. Both had their pros and cons, their risks and benefits, but neither was a perfect option, and so he needed to make a choice. But this was very difficult for him, and so he leaned very heavily up on me as someone in the medical field to help him with this decision. So again, I found myself kind of going through the questions on this wheel above, but this time with the family bent on it. And this kind of brings me to the talk, the focus of today's talk. How do we as physicians face and handle family members becoming ill? How do we choose to represent ourselves within our families? What resources are there to help us navigate the situation, especially during residency? and what are potential effects on our bandwidth or stress on our relationships with our coworkers. And then what ethical questions may we face in this process. These are just a few of the topics that we will cover in today's talk. So here's an outline we'll be reviewing. So dividing the topic into some of the practical and logistics, as well as some personal aspects. So we'll spend some time with each of these, starting first with the logistics. Now, most of my talk will be through the lens of a resident, pertaining to life as a resident, but certainly some of these points will relate to life as attending and beyond. So one thing that I was just struck by was just how common this was for people that I knew, whether it was amongst our co-residents here at UCSF or my close friends at other residencies, and even along the fellowship trail. Many of them had or were going through a situation like this at the time. Many of our conversations centered around conversations about taking time off, resident coverage, as well as some mental health issues as well. So given how often I was hearing about this made me want to dive a little deeper into the topic. So in an effort to get some quantifiable data, I sent a short survey out to our ortho residents, as well as a few other residencies, to see how common this experience was. And a little over 60 residents responded. When they were asked, when someone in your family, your nuclear family, experienced significant illness or had a significant surgery or procedure during your time of residency, nearly half said that they had experienced this. When the same question was extended out to their extended family, as one might expect, there was a good uptick, with 73% saying they had had this experience. Since many people consider their in-laws and their partner's family part of their familial circle, the question was again asked to include them, and approximately one half of residents had experienced this. So as you can see from the results, this is a very common situation. And so while going through one of the most busy times in your life as a resident, there's a really high likelihood that you may have some compounding stress with a family illness that you may need to attend to. Now, these results are just among the residents, but these numbers will all eventually reach 100% as we continue to age and our families continue to age, and we interface with more morbidity and mortality within our families. So whether it be stroke, infectious disease, cancer, or dementia, all of this will have this topic touch us in some way as physicians. So now, because we're in the medical profession, there's often an expectation from our family, from our loved ones, that we are always available in some capacity to help medically. From the survey I sent out, approximately 97% of residents had been asked by their family members for medical advice, with about 57% saying this was happening quite often. And this is by no means a phenomenon reserved only for residents. In this article from the New England Journal of Medicine, they surveyed about 460 physicians or so on the subject, and they found that 99% reported that they were involved in their medical family concerns. And on the table to the right, you can see a breakdown of the medical activities, such as prescribing medications, performing medical exams, and a surprising amount were even performing elective surgeries on their family members. This study from the Journal of Head and Face Pain surveyed neurologists and found that 80% had been treating their family members for acute minor illnesses, and 30% had reported treating their family for chronic conditions over the last year. And these patterns are not only seen in the US. In this study from India, 72 doctors were surveyed, and you can see very high rates in the array of medical services provided to their family members. Additionally, you can see that about 3/4 of the physicians were having at least 5 family requests per year. Similarly, this study from Japan, again, shows high rates of involvement in everything from acute medical problems all the way down to minor surgery. Now, given the complexity and the bottlenecks and the fragmentation of the U.S. healthcare system, not only may we be asked to help with medical advice, but we may also be helped or asked to help shepherd our family through this medical process. The residents polled, almost 2/3 of residents have been asked to help navigate the medical system in terms of setting up appointments, arranging specialist referrals, and trying to expedite components of their family's care. Of the residents polled, 1/3 had needed to take time off during residency to attend to matters involving the sick relative. And 1/3 of residents also reported having difficulty finding time to go deal with this and take time off to deal with a family member. So as one can imagine, all this can take considerable time, and residents tending to sick relatives can potentially strain the larger system. So what are some of the options for handling this? What systems do we have in place and that can help residents and their broader programs handle this situation? So to arrive at solutions, it likely requires a combination of systems approaches and cultural calibration applied in a case-by-case manner. And surgical residencies have some features that make this combination a little bit more difficult. So we'll spend some time discussing those next. So some of the features that complicate attending the family illness is the simple fact that surgical residencies are quite lean. And so there's very little redundancy just built into our system only on numbers alone. We have 37 residents total in our class or in our program. For comparison, the internal medicine intern class has 64 members, with the entire residency having 184 residents in this total program. Furthermore, junior residency is the bulk of our cold burden, and it's pretty high frequency, around 2 to 3 times per week. And moreover, we're providing an array of consult services such as reductions, splinting, bedside INDs, arthrocenteses, which all require a certain level of ortho expertise, which are not reliably covered by other services. And so we really need to be present kind of at all times. Additionally, within residency, there's a gradient of roles that matches our graduate responsibility. And certain cases are not really easily filled by newer residents. So, for example, a junior resident is not usually asked for taking on the chief roles at the county if a chief is out. So the combination of these features together can make the system predisposed to hardship when a resident is absent for any number of reasons. So now in the case of severe and prolonged family illness, there are more significant mechanisms that a resident can take if needed. These include taking leave under the medical leave policy of the ACGME, which provides a total of 6 weeks of paid leave, with an option to extend that to 12 weeks under the FMLA. But one should note that there's no obligation to be paid past the 6 weeks. So that's one thing to consider if you need to take a longer period of time, although you are able to contribute some of your vacation days or some of your sick leave to that total 12 weeks. But now, in most cases, taking extended leave is not really required to handle the medical emergency, but that, in some ways, creates some gray area in accommodating the shorter time periods. And I was reminded by a short discussion I had with Dr. Diab about this, in which we discussed the sheer volume of dollars spent in U.S. Military, as well as the spread of U.S. personnel across the globe. He made the point that despite what many reasonable people consider to be kind of an overextension and overabundance of resources, it is somewhat helpful, essentially responding to military conflicts around the world in a timely manner without ever really stressing the system at large or creating vulnerabilities elsewhere. So in some ways, it fosters a sense of redundancy and flexibility that's been helpful for preserving the U.S. superpower status for many, many years. And in many other ways, we are actually like the military. One, we are a very ancient profession, dating back thousands of years. We have a chain of command in the hierarchy. We deal with life and death situations from time to time. We have lots of fancy, cool gear and tools that we get to use. And we also have some pretty sweet uniforms. Sorry, Dr. Ma, that's probably more appropriate for you. But more importantly, we both serve our broader communities with an expectation that we as a whole are always available without fail. And this sense of duty, although it's something to very much be proud of, can also mean that at times that we put our health and health of our family members on the back burner. So this prompted me to think of some ways that residency can create some redundancy and flexibility within its own system to respond to these kind of absences, many of which I believe our program does actually quite well. Now, we obviously don't have a limitless budget like the U.S. military, but we have been on a trajectory expansion kind of streak here with buying new healthcare systems, and now they all kind of fly underneath the UCSF flag. So there's some opportunities probably to emphasize some strategies over others. So for example, expanding the residency size when the volume allows, as well as augmenting the program with PAs and Ps when funds allow, is both a way to increase our ability to partake in our surgical responsibilities, as well as provide an important release valve for clinical duties if a resident is absent. For example, the recent addition of an 8th resident essentially was able to rectify the dreaded Q2 call at the intern blocks at the county, which also by definition created more redundancy. Another strategy is increasing the moonlighting pay raise and the size to incentivize participation. When our family implemented this for the show, it almost instantaneously resolved the primary call issues while creating an abundance of very willing moonlighters. Now, as for flexibility, having dedicated protected time off allowed me to coordinate with my father to attend some of his appointments and debrief some of his consultations. Additionally, having some built-in variability of your rotation intensity and the addition of research blocks does allow for some surging and flexible movement of residents throughout the year as needed. And this brings me to the cultural component. So this is a list of some of the excerpts from some qualitative studies from JAMA, the American Journal of Surgery, and the Iowa Ortho Journal that examine perceptions of general surgery residents and ortho residents and their program directors for residents who were taking paternity or maternity leave. Now, there were no studies I could look at that I could find that looked at specifically familial illness, but the concept of paternity leave and maternity leave are very adjacent to the subject. Moreover, within these excerpts are many of the concerns that I felt and other residents I talked to felt when having to deal with family illness outside of work. Fear of making other residents cover their work, fear of being a burden, and then for many programs, the reality of literal no redundancy built in. But also within these excerpts, I think lie some gems for how a healthy cultural crosstalk amongst residents, faculty, and staff can be developed to approach these family illness situations in a compassionate way while ensuring collegiality and function. So in regard to the resident culture, I think worry about extra work and all coverage can be mitigated by a continual reinforcement that our collegiality and our collaboration is key, not only in running a service, but also ensuring that residents feel seen as people beyond what they can just produce for work. Furthermore, a resident being a hard worker and reliable at baseline allows for a good reputation to be built and hence preserved when they may need to step out for a day or so to deal with a family illness, which can be very helpful for them. And also the emphasis on reciprocity can't be understated or overstated. So, if you're able to have someone help cover you, it's always a good idea to return the favor when the time comes. As far as the attending side, reasonable worries about the service not being able to run or function due to the resident absence, as well as concern about potential loss to that resident's educational opportunities can definitely be addressed, at least initially, by having some approachability so that we can approach these and plan for such absences. So the ability to discuss coverage, the ability to plan for scheduling later opportunities for educational opportunities that were missed, these can all happen by establishing a little bit more approachability with our attendings. Moreover, these moments of openness and understanding, I think, are very important substrate for forming long-term mentorship relationships, which should also be one of the objectives of our residency programs. And furthermore, these dynamics are often at play with a number of other resident life situations. Someone needing to take a family illness day off is rarely happening in isolation of a resident on vacation or involved in having a baby, or as we all know in the wake of COVID, a resident themselves becoming ill. So these scenarios are all happening simultaneously, and each of them deserve their respective dues. And these are some of the components of developing a livelihood of a resident that started much before residency and will happen and continue way after it. So cultural shifts and decisions about investments, such as hiring APPs when funds allow, should not just focus on resident work calculations, but should also consider how these decisions impact residents' ability to maintain their personhood. A robust and thorough ortho education is not mutually exclusive to providing adequate tools for residents to still be a human being. So now to switch a little bit of gears towards the ethics and the legal side. And so when we're thrust into this role with our families, there may be a list of kind of ethical and legal quandaries that one may face. So this I thought was a very interesting article from the Journal of Plastic and Reconstructive Surgery, which surveyed 400 members of the American Society of Aesthetic Plastic Surgeons and on the issue of operating on family members. And surprisingly, 88% reported that they would operate on a spouse, and 84% reported they had already done so. So they reported that their main motivation was their belief that they were the best surgeon for the procedure, with the most common procedures there listed at the bottom. As a tragic follow-up to that, here's a news story out of Florida from 2023 in the Economic Times about a plastic surgeon who performed multiple surgeries on his wife. During one of them, there was an intraoperative complication potentially caused by a medication that was given, resulting in a cardiac arrest, a coma, and then later having her life support withdrawn in the setting of extensive brain damage. So now, this is obviously a very extreme example, but it does elicit some questions about the ethics and legality of treating our family members. So questions as fundamental as, should I even help at all? May not be so straightforward in certain situations or within some family dynamics. How do you decide to help? Are there appropriate ways to do this more than others? How do issues of conflict of interest and bias influence our recommendations? And are there any implications for special treatment for our family members? Legally, how are we bound and are reliable for medical advice that we give to our loved ones in unofficial venues or in unofficial channels? And so the American Medical Association does have some guidance on this matter. So essentially they state that treating family members should only be reserved for emergency settings or for short-term minor situations. They cite concerns of bias, conflict of interest, and confidentiality in their opinion on the matter. The California Medical Board also has a code of ethics, which mirrors some of those of the AMA. They state that even though there may not be a law specifically prohibiting such interactions, they still pose a significant risk in terms of impartiality, confidentiality, and then the risk of a conflict of interest. The board does cite that there are some California laws on the books that essentially require prescriptions to be made with an associated exam and medical indication, and that these are supposed to be linked to a medical record. Of note, not all state medical boards are the same as regards to reviewing your state's regulations where you practice is also recommended if you want to treat family members. However, a large portion of our interactions with our family members who are ill fall more in the category of diagnosis and informal examinations. In addition, we often get the question, is this serious or not serious? Which may at times feel a little bit uneasy because we're not always doing a full examination or a full history on them. And aside from those concerns, as evidenced by the resident survey, we may also be tasked with helping our family members navigate the healthcare system. Therefore, there is an expectation that our position within medicine affords us some power to kind of expedite these appointments, set up referrals, and in some cases, we are able to do this. For example, I think many of us on call have gotten a text from an attending saying, hey, so-and-so is coming to the ED, a parent, a neighbor, whatever it may be. And this does set somewhat the ambience for a VIP encounter interaction. In this study, there was interesting findings from the general practitioners in Germany. They were surveyed on the location and the rate of documentation of treating a spouse. They made a distinction about whether the spouse was registered in the GP's clinic. When the spouse was registered, the vast majority of them did not treat in the office, nor did they document the encounter. However, when this was registered in the GP's office, these numbers decreased with higher rates of documentation and in-office treatment. Similarly, the same pattern was observed when GPs were asked about treating their parents in terms of location and documentation. The study also looked at reasons for and reasons against treating family members, and they ranked the specific reasons on a scale from 0 to 5, with 0 representing never the reason and 5 being very often the reason. And they averaged responses and then ranked them in ascending order. The top reasons for treating included the practical convenience and reducing wait times and improving logistics, or that the illness was essentially minor. Other top reasons focused on family dynamics, such as the family had a great confidence in the GP's ability, or that they just simply expected them to do so. The top reasons against treating was that the illness was falling outside of their kind of scope of normal practice, as well as if the illness was considered very severe, or if there was significant fear of losing objectivity. In this study that I had referenced previously, they also looked into the same question. Here you can see high rates of worries about loss of objectivity, confidentiality, emotionality, complicating the medical decision process. They found that fear also and potential embarrassment played a large role. Worry about misdiagnosis, revealing adverse outcomes, and even performing examinations were quite prevalent in this study. So as for the legal ramifications, there are a number of papers and articles that discuss the topic. Now, without getting too much into the weeds and all this case law, the short answer to whether or not you could be legally liable for treating a family member is yes, you can. But this largely depends on the degree of contact with the family member, the way in which the medical information was relayed, the amount of documentation present, as well as some of the responsibilities either explicitly outlined or implicitly implied about the responsibility for said recommendations. And so this quote from one of the studies, I think, is a really great summary statement on the matter. It says, it is well established that the existence of a physician-patient relationship is a prerequisite to any malpractice claim. The physician-patient relationship is consensual in nature and is based on the idea of contract, whether implied or expressed, whether expressed or implied. Typically, the scope and the nature are not explicitly agreed upon at the outset. Rather, the relationship involves and inferred from the communications and the conduct of the physician and the patient. So personally examining the patient or expecting payment for services, features typical of formal consultation would certainly establish a legal relationship. So in essence, this is saying the more that your interaction with a family member starts looking like a normal interaction with a non-patient, the more you may be crossing a threshold of liability. And therefore, you may want to take steps to either formalize that relationship or change it in a way that feels more comfortable to you. Now, many of the articles that I looked at also provided some ethical and legal frameworks to help guide physicians in these matters. For example, this article from the American Physician Journal breaks down the matter into ethical, financial, and recommendations, as well as a few miscellaneous ones, including VIP patients. This opinion piece from the Journal of Anesthesiology also looked at different ethical and philosophical principles that can be applied to the situation, as well as offering a list of questions that the physician could ask his or herself about the suitability or effectiveness of their involvement. So such questions such as, am I trained to meet my relative's needs? Am I too close to the relative? And even questions about, will my involvement essentially induce family conflict? I thought were all important ones to ask yourself if you do get involved in family matters, especially if there are strong feelings about treatment options that may differ across your family members. Another article that we referenced created this fishbone model that I think does a great job of listing and organizing the many concerns that a physician may face. So kind of almost serving as a checklist of sorts, so they can help guide your thinking around taking care of a family. So such questions as maintaining confidentiality, looking at the laws and regulations. Are you having a chance of missing a critical diagnosis? And even like your social norms and your professional relationships. These are all things that can be accounted for on this list and would be helpful to go through if you're going to choose to treat your family member. So now if you or someone you know is going through a family illness, I highly recommend a close reading of some of those articles. And certainly it helped organize my thinking around helping my father with his prostate diagnosis, as well as a treatment course. But in effort to synthesize some of these ideas and kind of put them into buckets, I'll list a couple of themes here that I thought were helpful. So first, knowing your limits of your medical knowledge expertise is quite important. So in addition, be aware of your own tolerance for involvement in family medical concerns. This can help avoid getting into unfamiliar situations or territory, or just unwanted responsibility with your family. And then you can direct those concerns to a more suitable and willing medical professional. Be transparent with your family member about the concerns that you may have about being involved in their care. So discuss openly and early if there are any legal or financial aspects of the care that may arise. Be transparent about the nature of the tests and examinations that you are either going to do to them or recommend to them, so that they are fully aware of what the recommendations entail. Also ask for transparency with your family with what they expect. And so any discrepancies can be dealt with early on and sorted before you get too deep. Have an idea of what biases and conflicts of interest that you may bring to the situation. So as a surgeon, as all of us trained to be in surgical residencies, we may be more inclined to recommend surgical treatment options as opposed to medical ones. So this is often at play with oncologic pathologies, which there's both surgical and medical treatments that are both viable. The perceived inconvenience of treating a family member, as well as their potential expectation that you do so, may exert a pressure on you to make recommendations that you may not be fully comfortable with. So essentially take time to account for this and see if this is actually exerting a force that is discernible. And then the old saying goes, if it acts like a duck, then it's probably a duck. So that is to say that the more your interaction with a family member looks like a normal clinic encounter with a non-family member, you may be perceived as legally having one with them, either among the legal system, among your peers, and among your family. Therefore, if you want to continue providing care, consider formally documenting the episodes and the rationale for your recommendations. Consider having the visits in a formal setting, such as your clinic, and obviously make sure that you apply all the same standards of confidentiality, such as with HIPAA requirements. And then I will also say, consider how your involvement in families matter and the healthcare navigation, whether that be reaching out to colleagues or reaching out to get tests expedited or studies expedited, how that can affect your colleagues' workload, as well as their duty to their other patients who also deserve a thorough examination and treatment. And lastly, I would say be aware of how your family dynamics may vary across different members, such as those with your children versus your parents. They may have different implications for your responsibility, their autonomy, as well as their motivations or willingness to proceed with your recommendations. Now, throughout the talk, I just wanted to focus more on the family illness can affect you personally. So going through the situation can certainly alter the dynamics of a family unit. It can either potentially exacerbate pre-existing fault lines, or it may unify the family around a kind of common enemy, a common cause. And so this can obviously be quite variable across different physicians and across different respective families and the nature of the illness that's present. So I'll just talk real briefly about how my father's diagnosis affected me across some of these things and some things that I found challenging and helpful. Now, when my father was first diagnosed with prostate cancer, there was really no hiding from the expectation that I would be heavily involved in his care, even if I had wanted to. So him being a proud Nigerian father essentially ensured that everyone in my family and the extended family knew that I was a doctor on account of him introducing me as Obi Ajulu, his firstborn son, with a medical doctorate. So I was really identifiable as the family doctor. I couldn't just duck my head down like I was on the plane of the Curb Your Enthusiasm episode. Now, prostate cancer was not the first time my father had a significant medical concern that our family encountered. Back when I was in middle school, my father was hospitalized and collapsed in his office after finding a bleeding ulcer that had resulted in significant blood loss. We had visited him in the hospital. During a short admission, the GI docs decided to not cauterize the ulcer because on this initial EGD, there was already a clot that had formed. So that night, after he was discharged after 2 days, we all celebrated with him being home with a movie night in the family living room. After the movies had wrapped up, I went down to the hall to go brush my teeth, and then suddenly I heard a loud thud and then the shrieking of my mother and brother. I ran back out to see that my father was face down in a pool of blood and was seizing uncontrollably. And so we called 911 and had the ambulance come, take him to the hospital, and he was stabilized there. This time they did decide to cauterize the ulcer, as they saw in his EGD that had opened up and had dropped about a liter of blood in his stomach. So now fast forward to approximately 3 years ago, my father was diagnosed with prostate cancer in the intermediate risk category, again, which radiation or surgical resection were both options. Again, as I had stated before, there was no perfect option, and my dad was quite paralyzed with the understandable indecision. So over the course of a year, we had numerous consultations with urologists, surgeons, radiation oncologists, all with little progress. And so my initial understanding of my dad's decision began to turn into some frustration as the clock I felt was ticking on a much worse outcome for him. On top of the stress of the logistics of participating and debriefing in his multiple consultations, at times he needed to take a vacation day or two to attend these. My fears were further flamed by many oncologic encounters that we have at Residency. So whether this be scrubbing into spine debulking cases, nailing pathologic femur fractures or tibias, seeing PET scans light up on our PAC system, and even our encore lectures were continuing reminders of the worry that we had of my dad's course. So in the interim, I couldn't help but feel as though I was being transported back to the middle school version of me. Instead of losing my dad through hemorrhage acutely, thought maybe I was going to be losing him slowly over months to cancer. Now, my stated preference for him to undergo a surgical resection, although admittedly I was likely exhibiting some bias as I'm currently going through a surgical residency training, but I did try my best to have the final recommendations of the provider take center stage and told him transparently that I did not want to play the role of providing treatment. Now, as someone with an immigrant father from Nigeria who was very proud to have a doctor's son, this at times felt like I was letting him down by not being his doctor. However, eventually he did pick a treatment to go on to undergo a radical prostatectomy. The final surgical pathology did report clear margins with no signs of local metastasis. Now, some of that joy of hearing about the clean resection of my father's cancer were tempered by his intra-op complication of labile pressures and arrhythmia that required a post-op stay in the ICU, his readmission to the hospital a few days after discharge for acute urinary retention after a blood clot had clogged his Foley, as well as the development of some hernias from the laparoscopic incisions that will need to undergo surgical resection later on. And inevitably, when you feel like you've introduced a recommendation to your family member that then has complications, there's a sense of guilt that arises from that. And because certainly this had to do, this influenced his decision to undergo surgical resection with my preference that he do that as well. But despite those complications, my father's doing quite well and is happy, and my family as a whole is feeling much better to have the scariest part of the saga in the rearview mirror. And so reflecting on this experience, here are some things that I thought I found quite helpful throughout. They kind of served as a residency checklist to go through that I would kind of run through periodically. So first, if you have permission from the family member, disclose it to your friends and your colleagues. Say that you're going through this. Don't go through this alone. And when I opened up about this to my co-residents and some of my attendings, not only did I find it much easier to plan for coverage and for other issues, I also found this incredible reservoir of support and care from those people, and I'm extremely grateful for them. Acknowledging the limits of your expertise. Again, you are just a resident, and so you don't know everything, and you certainly don't know that much outside of orthopedics. So set the stage with your family about this, and make sure that they know that there are contours to the limits of your knowledge. And this may help you stay out of ethical situations, as well as not overextending yourself with your family. Realize that you cannot do everything. So if you're already doing multiple research projects, you're very busy on your clinical duties, it's okay to say no to some things. Not everything, but some things, because it's important to remember that your family does not disappear during these 5 years of training. For the fears, anxieties, and even some of the guilt that I had felt during this period, talking to a therapist every few weeks was extremely helpful for me, and helped me stay sane and help navigate some tricky family dynamics. So I highly recommend that any of you who are going through this, seek out some family therapy, and that might be very helpful to you. And lastly, use the experience of your residency to help communicate with your family. This is a privilege that we all have, and it's a tool that we all have. So I was able to genuinely express my concern with my father about his delay in treatment by talking about stories of patients I encountered on the wards, whether it be in the ED with pathologic femur fractures or with wide metastatic disease. And I think this did help kind of spur him to make a decision in a way that felt very real to him, and very genuine to him. And this brings me to my closing point. This was the last question I asked on the survey. I asked, did going through a family illness make you a better doctor, a worse doctor, or had no effect? And very happily, the results showed that most of us thought this made us a better doctor, 76%. Now, there's certainly a risk that going through a family illness during residency may chip away at our ability to be effective, compassionate physicians. Baseline additional stress can negatively impact us. Helping our family through a difficult, fragmented system may also drive some sense of disillusionment in the system in which we work. And the possibility of countertransference, or essentially projecting some of our fears and concerns onto our patients with similar appearances or diagnoses, may cloud our clinical judgment. Although these negative effects do certainly exist, I believe the potential to harness the positive lessons from the experience are much more lasting and prominent. Just as some of the patients I encountered helped me find a language and connection to my father to help him with his illness also helped me communicate better with some patients and their families. There have been times in residency, I think all of us have experienced, where a patient or a family just can't decide on a medical decision. And when time is of the essence of residency, this can feel very frustrating when you're just trying to make decisions for the service. But remembering that I was similarly going through a decision lag with my father on his treatment course helped temper some of those frustrations. Also, we go through quite a huge dip in our empathy and our sympathy levels here at residency because we're just so busy and the degree of hardship that we face. And so sometimes a family illness may be really important for rejuvenating that store so that we can then export that to our clinical practices. And so overall, we set out to become doctors to treat our communities, but our family is part of our communities. And the lessons learned in that venue can be utilized in the other. And this crosstalk, I think, can help preserve our humanity and our ability to connect with our patients, which is needed to become and remain effective, compassionate physicians throughout our careers. So here are my references. And so quick thank yous. I want to say first thank you to all my co-residents here. You guys are all incredible human beings. I'm very, very honored to be working with all of you. I hope all of you are doing well. Thank you, Dr. Feely, who's been one of my great mentors dating all the way back to first year of medical school. Thank you, Dr. Diab, who's been very helpful in creating this grand rounds and has always been a relentless force for thinking big and differently. Thank you to the spine faculty for your mentorship in getting to this point and applying into spine. I can't believe match day is next week. Holy crap. And big thank you to my family and my father for being so awesome and for allowing me to speak so openly about this. And to my partner, Maria, and our dog, Kaya, who've been there through thick and thin. So thank you all for listening.
Great. Here's it. Distinguishing the request and the person. That's the vocal.
Yeah, no, that's a great question. I think because we're orthopedic surgeons are heading on our way to that, our impulse is to want to fix things. We want to put nails in things, screw things. We want to, make things straight. And so I think we have an ability to unfortunately do that with healthcare situations or our family, which may feel kind of like a mismatch from what maybe they need. And there are certainly times that I felt that I was bumping into that. I felt like, oh, let's just get this cancer out. Let's just fix the problem, right? But there was a whole other host of concerns that my father was having that weren't just the simple yes, no cancer. And so I think some of that's about trial and error, right? I don't think you'll be perfect in that regard. I think eventually, if you're coming up against a situation in which there's a lag or there's some, frustration, I think just asking them, what are you afraid of? What are your fears? What's really driving your concerns? And then that may help kind of give you a second pause to say, maybe it's not really that they're looking for a prescription of sort, but they're looking for someone just to listen to them.
Any kind of that are covering like what your in experience where one of my there was a person nearby who dropped by to offer a couple words of advice and then dashed off, and I think they were a doctor who was afraid of becoming involved in the situation. So I'm curious if you came.
Yeah, I think there's lots of books, and they may vary from state to state. I think most of the time you'll be given the benefit of the doubt if your recommendations and involvements are proper, and kind of you're making sure that people know your position, and as well as kind of making sure that the advice that you're giving is always couched in, I'm not your full doctor. I'm only kind of seeing you for a sliver of the time here, and so any recommendations that I'm given should be weighed against the people who are seeing you more long term. And so I think you're always going to get the benefit of the doubt, but there's certainly times if that interaction goes past just kind of this fleeting experience that you may be, on the hook for more, maybe look for the advice that you give is more formal or more prolonged.
Thanks, AJ, for a great talk today. I think something that most of us can definitely relate to. You touched on this a little bit during the talk, but in my experience, when family comes to you, they really want you to have an answer and you to have a stand or a recommendation. And so how did you approach, telling your dad, I have my own opinions, but I can't be your doctor here. And, I think you touched on it a bit, but do you have any advice for us, going forward when we're not in a position to treat our families or make those final recommendations? How can we let them know that?
Yeah, I think this is an interesting balance, because I think it brings in your sense to be a loving, child or relative, with the risk of feeling like you're becoming cold or distant by trying to put some space between you and their medical situation. I would say, be aware that pressure may make you make recommendations that you're not fully comfortable with, or that you feel are kind of expediting the process to maybe get out of an awkward situation, and you don't know how fervently or how strongly that relative may grip onto your recommendation because you are a doctor. So I think it's something that you have to be really careful about. For example, the recommendation, my feeling that I want my dad to go through a surgical section, he certainly latched onto that, even if I did say, hey, that's my recommendation, and that's what I would do in my situation. But, you need to be able to have your own kind of host doctors deal with that. So I think I think it was a continual reinforcement that, yes, I am a doctor, but I'm not necessarily your doctor. And then I think you should always take the whole kind of menu of options and weigh them. I think also one thing that's helpful is if you help them weigh those options in a way that's inclusive, then they feel like you're still participating, but also you can be playing a role that's more the mediator of options or recommendations as opposed to being the final say.
Dr. Inverman has a question on Zoom for you.
Oh, yes. How do I?
AJ, thank you for your talk, and thanks for sharing your story. My question is regarding the legal framework. You mentioned how if you're writing a medication for a family member, or any medication really for anyone, you have to document it and kind of have some record of maybe evaluating the patient. So, for example, if I write, antibiotics for my kids, am I then better off actually leaving a note somewhere? And in that case, where does UCSF stand on that? what are issues regarding documenting in your family's charts without seeing them like in clinic?
Yeah, it's really tricky. And so I think there was a long period of time when a lot of prescriptions can be did by verbally or over the phone. Now the laws are kind of saying that most of your prescriptions need to be done electronically, even for things like antibiotics and things like that. So that essentially is necessitating some type of system, footprint that you've seen them. And so I would say, yes, I mean, somewhat use your own discretion about how willing you are to kind of fully take the letter of the law to the land. But I'd say if there's any question, or if there's, the severity of the illness is maybe more than just like kind of a normal cold or whatever, maybe having a documented thing in there is important. I think secondly, you could also, ask one of your colleagues to help with that scenario too. So say, hey, my kid's so-and-so is sick. Do you mind seeing them real quickly, writing a quick note, and then maybe prescribing some medication as they see fit. But again, there's this big push to put everything electronically, which I think is kind of demanding this footprint be present.
Sense. Got a sense.
Yeah. So I looked into this too. Yeah, I looked into this too. There is similarly no specific law in the books that say that like a lawyer cannot represent their family or thing, and it actually happens very often. I'd say it's even more common than probably physicians like treating their own patients, unless you're a plastic surgeon, of course. But they do have similar code of ethics. I think is kind of where a lot of this stuff lies. Is be aware of your bias implications for your confidentiality or other things like that can arise. So much of this is kind of in the eye of the beholder of the person who's doing the recommending or the help. So it's just good to be aware that there are codes, but there's very rarely just specific laws that prevent this across many professions. Cool. All right. Thank you all.